Yes, so good afternoon, everyone. Thanks for joining us to this sponsored session that we have the opportunity to deliver thanks to our sponsor, Inside LifeTech. This session is dealing with an interesting topic, which is the pressure microcatheter guided percutaneous coronary intervention to optimize stent implantation and to safely assess the functional result. I mean, I've attended several sessions at this Euro PCI, and there is nothing, we are just talking about this all the time. So physiology, not just to indicate revascularization, but also to guide all the way through this revascularization and possibly to finally assess this revascularization result at the end. So what are we here for? We are here to share current trends in invasive coronary physiology, and we have a dedicated lecture on this. To understand the key role of longitudinal functional evaluation of coronary artery disease, we will learn more about this second dimension, as Carlos Collet likes to call it, in coronary physiology, and we will share, that's important, tips and tricks in using pressure microcatheter in PCI indication and guidance. I'd like to emphasize again this important wording, sharing, and we are fortunate enough not to be so many this afternoon, so please try to join us in the conversation, and if you have comments, questions, objections, just help us in the discussion. And I'd like to hand over, well, this is our team. I forgot, I've included this slide. Gianluca Campo from Ferrara, there in the panel, is the co-chair. Carlos Collet from the Cardiovascular Center Aalst is one of our discussants. Connected with us from China, there will be Professor Jumbo Ge. By the way, he's already connected with us, so in case he wants to intervene, we'll be happy to hand over the word to him. And our chat master, Emanuele Gallinoro. That's for you.
Yes,
Gianluca.
Thank you, Emanuele. Please remember this is an interactive meeting, so we would like to suggest to use the chat or the microphone for the question and for the discussion. With me will be present Emanuele Gallinoro, our chat master. So your question, if you prefer, use the chat, and Emanuele will discuss with all of you this question. Thank you.
So I think we are quite ready. We set the stage, and let's try to address the first question, Carlos, so if you get to the podium. So to Carlos, we ask, why don't you tell us what are the current trends in coronary physiology, whether we made some progress, how far we are. Carlos.
Gianluca, Emanuele, thank you very much for inviting me to this session. I'll try to end this presentation and show mine. Very good. And I really like the title because it's addressing, of course, where we are today. But I think the way to address this question is also kind of understanding from where we're coming and where we're going. So this is a bit the way that we are going to deliver this message. These are my disclosures. And it's not strange that everything started like this. This is the first intracoronary pressure pullback performed in 1979. By Grunzig, and this is in his seminal paper in New England in 79 again. And we see again that he nicely demonstrated in one of the first cases of angioplasty that this was a patient with a focal lesion. And we start to see here how he identified the gradient, the translesional gradient, and of course dilated that vessel. And he didn't stop there. He also measured post-PCI pressure, which would be the equivalent today of measuring post-PCI FFR. And you see how nicely he demonstrated that after PCI or after angioplasty, that is the white dot, there is a reduction in the mean pressure gradient. Again, 1979. Today, 2022, and this is probably going to be published in 2023, the paper is under revision, we have performed the largest individual patient-level meta-analysis addressing the consequences of post-PCI FFR. What you see on the screen is the incidence of cardiac death and myocardial infarction stratified by post-PCI FFR. You see in the Kaplan-Meier curve, the blue group is our patients with low post-PCI FFR, and the red group are patients with high post-PCI FFR, and you immediately see that the patients with low post-PCI FFR have almost 40% more risk to die or have an MI. Of course, this is easy to see high and low, but actually post-PCI-FFR as pre-PCI-FFR is a continuous metric with lower values of post-PCI-FFR conferring higher risk for death and MI. So where we are today, this is what we understand. We understand that post-PCI is related to MACE. We understand that post-PCI is related with angina. But this is actually a bit more complicated. Post-PCI-FFR depends on the disease pattern. Diffuse disease is associated with lower post-PCI-FFR. The use of intravascular imaging for stent optimization has also been shown to increase post-PCI-FFR. The PCI technique itself can also impact post-PCI-FFR and other baseline characteristics. Recently, we have also understood that what is important for the improvement of our patients in terms of angina is the change in FFR. So this is the current state of knowledge what concerns post-PCI physiology. So we have the impression that we're going back in the future. So from 1979, we're now realizing that FFR is not only a tool to assess lesion significance as proposed by Bernard de Bruin and Nico Pils in the 90s, but it's also a tool that helps us understand what is the pattern of CAD, focal and diffuse, and of course can help us to optimize PCI. And where we are today, I don't think that anymore we have any question that when you look at pre-PCI pullbacks, and what you see in the screen are two different patients. The patient on the right, you see that have an FFR of 76, but when you look at the pullback curve, you see there a diffuse pressure loss. This is a patient that will not benefit from PCI. In contrast, the patient on the right side, you see here that they have an FFR of 79, but this pressure is all lost within a short segment of the vessel, and that is depicted by this step in the pullback curve, and this is the ideal candidate for post-PCI-FFR. So we're using this technology to refine our clinical decision-making. What happens when you do PCI in focal disease? You get higher changes in FFR, and you do PCI in diffuse disease, you get less changes in post-PCI-FFR. And what is the consequence of that? Patients with diffuse disease have more residual angina compared to patients with focal disease after treatment with PCI. The new question that we have is how would the increase in post-PCI-FFR relate to the improvement of outcomes? We still don't know the question, but what I can tell you is that when we do a post-PCI-FFR pullback, three things can happen. We can have an in-stent gradient, that is the physiological consequence of external expansion. You can have focal stents outside the vessel that are we don't know what they mean, but we're able now to depict them pretty well, and probably will need to do an additional stent. And you have diffuse pressure losses that are treated with medical therapy. This was partially addressed by target FFR. I will not go into the details of the study, but I'm going to show you the primary endpoint. And the primary endpoint demonstrated that systematically using post-PCI-FFR pullbacks translate in a significant higher proportion of patients achieving an FFR post-PCI-FFR above 0.8. Thus, we can conclude that FFR has evolved from a diagnostic method to a tool that helps guide or refine decision-making and optimize PCI. A pre-PCI pullback with the PPG or without the PPG predicts the improvement in fractional flow reserve and relief from angina. The benefit or the harm of PCI in focal or diffuse disease is currently under investigation, and we are actively investigating the benefit of FFR-guided PCI in patient selection and PCI optimization in the insightful FFR clinical trial that will be discussed later in this session. Thank you very much for your attention.
Thank you very much, Carlos. Please join us here at the desk, and perhaps while Emanuele is getting ready for the clinical case. Let's just try to understand what is our practice here in the room, and let's inquire on the way you use intracoronary physiology in your patient. By show of hands, I'd like to ask you, how many of you in the room, when assessing physiology, would rather do single point measurement, just pressure wire down, and you measure resting index, hyperemic index, and how many of you do on top of this also a pressure pullback? So let's start stepwise. How many of you does single point physiology measurements? Please raise your hand. It cannot be only 1-2 person.
But it depends if you have a lot of lesions.
Yeah. I mean, your first step. How many of you does single point measurements, and how many of you does pullback? Let's put it like this. How many of you does also pullback on top of single point measurement? Raise your hand. Good. Now, how many of you repeats this measurement at the end of the PCI? Please raise your hand. Okay, slightly less. Good, that's already a good indication. We also prepared a practical clinical case to test this kind of strategy and to anticipate what will be the design of the insightful FFR trial. And Emanuele, if you can launch the first part.
Okay, so we now shifted.
I think
to
it's
the
just the swap.
where we
You took the second part. Yeah. Go back. Case presentation. Yeah, that one above. Case presentation. Yeah. Thank you.
Welcome in the cath of the Cardiovascular Center in Aalst, where we have a very interesting case, physiology case. And we have with us Emanuele Gallinoro, our fellow. And I would suggest that we proceed with the case presentation before we go to the angio and to the procedure itself.
Thank you, Jeroen. Thank you, Emanuele. So the patient of today is a 71-year-old lady with common cardiovascular risk factor, with a history of a previous TIA in 2015. And the clinical presentation is actually stress-induced chest pain. The laboratory investigations are unremarkable. This is the ongoing medical treatment. The baseline ECG and the resting echocardiography are normal, but the exercise test was maximal, positive for symptoms, but negative for signs of ischemia.
Thank you very much, Emanuele. While going live, we collected some baseline angiograms that we were discussing with Jeroen. Let me go all the way back to the left coronary artery first. We have already an intermediate lesion on this marginal branch, Jeroen.
Indeed, so it's a very focal lesion, appears to be focal, not so severe, if you ask me, but nevertheless we will interrogate and assess this one indeed using FFR.
Then we have this long lesion on the LAD that looks angiographically already significant, and here I guess we will explore the value of physiology guidance of PCI rather than indication to percutaneous coronary intervention. It's a long disease, so it will be very interesting to do pressure pullback here. And then let's go to the RCA again. There are a couple of intermediate stenosis at the mid segment, plus there is this more significant lesion, which is actually, as Jeroen was commenting, on this posterolateral branch, or acute marginal branch of the RCA. There you go. Good.
Okay, so we'll start by the preparation of the true Physio catheter. This is the over-the-wire rapid exchange catheter that is very useful in multi-vessel evaluation of FFR. And I will show you how we prepare the catheter and how we connect it to the Vivo Cardio station. So we flush the catheter. Once flushed, we will open it and attach it to the Vivo Cardio console. Please. Okay, and then the Vivo Cardio will tell you all the steps to further prepare. So, next. Okay, so we have zeroed the catheter, and then we take it out and we introduce it in the patient. So as we have explained you, this is a rapid exchange microcatheter with a CardioMEMS pressure sensor on the tip of the catheter. And it is a very convenient method because this is an over-the-wire technique. We use our standard workhorse wire to introduce the FFR catheter. Okay, so after introducing the catheter inside our guiding, we will start by equalizing the catheter. So this is done at the tip of the guiding, and we know that the pressure sensor is in between the two radio-opaque markers. We push the equalize button, and PDPA becomes 1. We have equalized. Next step is to introduce the pressure sensor distal to the lesion and as we have explained you before, it is an easy catheter to use. You just slide it over the workhorse wire, and then we will record the resting values. Okay, so we are ready to measure the fractional flow reserve. We have used papaverine as a hyperemic agent, and now we will record, and while recording, we will inject now 3 cc's of papaverine. We wait for hyperemia. Hyperemia is achieved after approximately 10 to 15 seconds. And you will see that the FFR is 0.76, 75 even. Okay, and then we will perform a pullback. The pullback is very easy as we're working over the workhorse, and we just have to retract the FFR catheter with the workhorse wire still in the distal vessel.
There is a very focal step up, Jeroen, at the mid-right.
Stop. The FFR in the right coronary artery is 0.73 with a relatively focal pressure loss in this mid-segment. And as you can see, no other gradients in the artery, and this in the end accumulates to a PPG index of 0.72, pointing at a focal gradient in the mid-segment of the right coronary artery.
Want to see more?
I have to go more distal.
Okay, I think it's perfect, Jeroen. Atmosphere, 40 atmosphere. We have to see this
Some residual disease
yeah, that's
everywhere.
Good. Let's assess them.
Okay, so we have implanted a 275/28 stent,
Right.
and we have seen that there's some residual disease in the right coronary artery. So what we're going to apply now is the PIOS principle, where we will measure the FFR, perform a pullback, and look for residual gradients outside the stent. That could be the target for an extra stent, of course, or a residual gradient within the stent, where you can end the procedure with a stent optimization, of course, to achieve the highest possible FFR.
Let's go. I would go just beyond this diseased segment. That's right. That's a good place to land. As usual, we give this 3 cc papaverine. We can start recording. Top. Okay. Still some residual disease, Jeroen, 082, 83. Why don't we localize this disease?
We will localize it. So stop, live, and we will perform a pullback record.
There seems to be a step up just beyond the stent, huh?
Stop.
Yeah.
Close first.
It's quite good, huh?
Yeah.
Okay.
Yeah.
12 atmospheres.
Gonna do the overlap.
Yep. Do a little bit below where there was a black.
Yes.
40 atmospheres.
There. Okay.
Okay, angio looks good. Okay, so we implanted this additional stent, 275/28, and we are doing now the, hopefully the final functional assessment. This is the resting gradient. I will induce hyperemia. Top. And the value is already reassuring.
Indeed, an FFR post PCI approximately 0.88. Stop.
Okay, we have to fix the sample volume correctly, but I don't see any residual gradient. Yeah, this is the post-PCI FFR. It was 0.8788. There seems to be diffuse gradient. I would stop the treatment of this vessel. Thank you very much, Emanuele. I'm always surprised, Carlos, when I see this mismatch between angiography and function. So there was quite of a stenosis in the mid-segment of the RCA, and I would have anticipated that there would be the place of high hyperemic pressure gradient. But honestly speaking, this distal lesion, I completely underestimated based on the angiogram. And I was impressed to see that after having stented the mid-RCA, the distal one became much more pronounced in terms of functional impact. What is your comment on this? I mean, is this something we should expect more and more, we should look for more and more?
You know, when you do these type of cases and you use physiology the way you have used it, we kind of try to recollect all the cases that we have done with the old strategy and what would have been the result of those that we didn't use post-PCI physiology. So this is the first remark. And what you have seen is something very simple to understand from the fluid dynamic perspective. So you have eliminated one stenosis, the flow has increased through the vessel, and it unmasked a second stenosis that was not visible because of the reduced flow when the first lesion was present. And this is one of the reasons why I think repeating the hyperemic functional assessment is very important to understand the degree of functional vascularization that we have achieved.
Gianluca, in your practice, if you had to manage this patient, how would you have approached them? You see, this patient has multiple stenosis. We started from the RCA. We still have to work on the LAD. You see how much work and how intensive it is if you want to do a good job and you want to have a fully functionally guided PCI. Share your thoughts and experience on this.
Yes, this case is very interesting, and the first, also in my opinion, we can start by RCA because RCAs look like the most severe stenosis. And my first step would be to stent just the mid portion of the RCA. So to use physiology in this case could be helpful to achieve a better vascularization RCA, and we will see continue in the case also to understand if we need to treat all the three vessels. This is really important. When you have a complex disease, physiology can be very helpful to simplify the procedure, achieving a very good result.
If there's any comment or questions, please take the microphone. Jacek.
I have one question to you regarding this hyperemic pressure pullback. Why don't you use just the rest pressure pullback?
That's a very good question. So we have understood that there are a lot of advantages of using resting conditions to measure coronary physiology. One of them, of course, is the absence of, put the adenosine, wait for hyperemia, time, cost, etc. Nevertheless, particularly in the right coronary artery, in situations that the flow is not so fast in resting conditions, when you do a post-PCI pullback, you cannot see focal pressure gradients. You need to increase the flow 3-4 times with hyperemia in order to unmask residual pressure gradients. So now we have learned quite a lot. That is a particular phenomenon related to the right coronary artery, that hyperemia is required to unmask these residual focal pressure gradients.
Hold on, Carlos, because I'd like still to hear your thoughts on the PPG. We heard in the video that we had a PPG above 0.5, it was 0.8, and we discussed about focal disease, but since you validated this index, why don't you tell us what does it mean, PPG?
So PPG, the name is pullback pressure gradient. So it's the pressure gradient that we measure during the pullback. And this is a diagnostic tool that tells you if the disease is focal or diffuse. It's meant to be used in complement with FFR. So FFR is 0.75 and the PPG is 90. That is a significant focal disease. If you have the same FFR and the PPG is 30, that is a significant diffuse disease. Why this is important? Because PCI is a focal therapy. So if we, and you have seen the data that I presented on angina, treat patients with focal disease, that patient will do pretty well. That's a patient that will come without any residual symptoms, and we believe that those patients, based on the research done on post-PCI FFR, will do pretty well long term. In contrast, when we do PCI in patients with diffuse disease or low PPG, these patients are the ones getting low post-PCI FFR, less improvement of angina, and maybe higher event rate at the long-term follow-up.
This is what we would call PCI planning, actually. You're anticipating already what you could expect after stenting the vessel. Why don't we see the remaining part of the case, Emanuele?
Okay, so we now shifted to the circumflex where we encountered a quite difficult or challenging wiring due to a short left main. But once the wire down, it's easy to advance the microcatheter, and we'll measure the FFR again.
4.90, that's good. 88, 89.
Okay, so the FFR is negative. We will nevertheless perform a pullback. Of course.
Yeah, this is the focal gradient at the level of that division.
Stop.
And so.
Okay, so now we will advance the microcatheter inside the LED, not really to confirm the significance, but in order to have an idea on the location of the gradients within the vessel.
As a matter of fact, Jeroen, we have a PGP at rest that we can record, please, of 0.44. It means that already at rest, this is a significant pressure gradient. Nevertheless, we will inject now the hyperemic stimulus in order really to unmask any residual microvascular resistance and to use this as reference value for post-PCI assessment. Why don't we record? We're still recording. Good. Top. There you go. Now we should be shortly fully hyperemic, Jeroen.
Okay. So as you can see, even in rest, there's already a hyperemic state with a PDPA that is already almost as low as the FFR.
That's right.
Okay, we'll perform a pullback. Stop. Live. Go.
There you go. Very sharp step up, proximal to this long lesion.
In this diffusely diseased LAD, we have a very low FFR with a very focal gradient in the proximal part of the artery with a corresponding PPG of 0.80. This means that this is a angiographically diffuse disease, but functionally focal coronary artery disease.
Ready? 1 millimeter more. There. That's better, right? Yeah. Yes.
Just got the distal lesion there, CFT. I think it's not too bad, huh? The one is not too bad. Let's do I would avoid to stent that one as well, hopefully.
Let's measure.
Let's measure.
Pios, like,
Pios.
Okay, so now we implanted a Trio 32 stent in a proximal to mid-LAD and we'll evaluate the FFR with the pullback post-implantation.
Not too bad. Why don't you film the pullback?
Good.
Yeah. Top. Okay. Let's go with the pullback.
Okay, stop. Three, two, one, stop. Okay, now is your gradient.
If you move it a bit, click on that one.
To check. At the end is 096.
Okay, there's a small drift, but it's diffuse disease, so we stop.
Okay, so thank you, everybody. It was a very interesting case with multi-vessel FFR interrogation. In the right, clearly positive, with treated with one stent, and then Pios showed us that we needed an additional stent to end up with a very high post-PCI FFR. And then the circ appeared to be negative, the LAD positive, and treated with one stent. The Pios algorithm showed us there was a residual gradient, but it was a diffuse pattern, no residual focal gradient inside nor outside the stent. So I think we can wrap up with an acceptable angiographic and both functional end result.
Very well done. Congrats.
Thank you very much. You can join us here, Emanuele. Perhaps if Jubog is connected from China, we can have him on the background so that he can participate to this bit of discussion. There is one point I'd like to discuss with Carlos, this manual pullback. How reliable is this manual pullback? We try to do it very slowly. If you can tell us something on this.
Yeah, so we have quite some experience with the pullbacks, Emanuele. So we started using a motor because we thought that was the most precise approach. So we put a big the pullback of the Volcano Ivus, the old one, in between the legs of the patient. And then we did that at 1 millimeter per second to be sure that was very precise in terms of the standardization between the pressure and the length of the vessel. And then we said, okay, maybe manual pullbacks are enough. So we said, okay, let's compare them. So we did a trial that was published by Jerome Song in CCI a couple of months ago, comparing what the information that we can extract from a motorized pullback from a manual pullback, and it's exactly the same. So it's, of course, doing a manual pullback reduces time, reduces the having the necessity of having additional hardware on the table, and I think that is enough. What I'm surprised, Emanuele, let me give you some feedback on the case. I was truly impressed how you did 3-vessel FFR, not 3-vessel because you did 2 or 3 pullbacks additionally, so you did like 7, 8 measurements, very fast, very easy, and I think you were working with your workhorse wire. And I think, can you give us some, what was the feeling of working like this? Looks pretty easy to me.
It is. It doesn't only look, it is easy actually, and that's the advantage of working with your workhorse wire, which is, like any wire you are confident to use, and the fact of having a pressure microcatheter that you can slide on each time you want and in the very moment you need during the procedure, preserving it from a possible stretch or stress that you can provoke when doing balloon dilatation, stent implantation. This is what can often happen or can happen to the pressure wire. Guess how many pullback we did before, during the procedure, during the stenting. So with the wire, this would have practically meant crossing and recrossing the stent. And we know it very well, especially when we stent over long segment, that it's not that easy to recross with your pressure wire the stent. That is the moment where we can have also dissection. And it happened to any one of us, this kind of issue. From this standpoint, this tool is facilitating our assessment. And you can do as many times as you want the assessment. And you see at the end, you said it well. This was the 7th or the 8th pullback. I had to cut, for the sake of time, this case. But we ended up with 2-3 millimeters mercury drift after a procedure of 1 hour and something. So it's quite good. By the way, if there is anyone who wants to comment,
or otherwise, Emanuele, I can ask you a comment about residual diffuse disease after stent implantation, because I believe it's a very important message for all the people that is not a failure of PCI technique. Is normal. It is really important to report this information to clinician, because we can optimize medical therapy, we can avoid in presence of residual symptom to repeat coronary artery angiography. So, which is your opinion?
It's totally right. Actually, this is something, as it was mentioned in the beginning, that we should take into account from the very beginning, before even embarking into a percutaneous coronary intervention. If we realize that there is a focal stenosis on a background of a diffuse disease, this can be still a case that we can take for PCI, because you know that you can at least help a little bit by restoring the flow segmentally in these vessels, take into account that you will never be able to achieve a perfect result at the end. But having brought these patients with an FFR initially of 0.4 up to 0.86, 87, means a delta FFR that is massive. So for sure, we did something good for this patient. I want to hear if Professor Gueux is connected. Can we have Professor Gueux on the screen, or at least have his audio? If I look there to the backstage, is Prof. Gueux with us or not?
Yes, I can hear you very clearly.
Okay, great. Welcome. Welcome to EuroPCI 2022.
Thank you, Emanuele. Thank you very much.
Jumbo, before starting with your lecture and giving your perspective from China, we would like to hear your comments about this case. I guess you followed the case during the session, and I'm sure you have done many of those in your practice. Tell us how this technology has enhanced your possibility to do physiology in this patient.
Okay, thank you very much. Actually, this case was very nicely demonstrated the beauty of this pressure microcatheter. Actually, as you mentioned, that if previously we used the wire, it is very challenging. It is not in this case. In some of the cases, when the lesion is too tortuous, with calcification also, it is very challenging to recross, to pull back. Now, this shows the beauty of the pressure microcatheter with the monorail. You can do repeatedly, you can do really any time you want, very fast, and it gives you a good result. In addition, with this pressure microcatheter, it gives less drift compared to the wire. Because for the bigger vessel, if you have the wire in the coronary artery, sometimes the pressure drift will happen. But with this microcatheter, because it fixes on the wire, on the workhorse wire, it just gives a very stable position no matter you measure. I think this shows the beauty of this pressure wire by putting back. Thank you very much.
Great. Why don't you share with us what is the current status of the intracoronary physiology there in China, please?
Okay, thank you, Emmanuel. Can you see my slide?
We do.
Okay, so I give a very brief overview regarding the current status and the intracoronary physiology and pressure microcatheter in China. I do not have a potential conflict of interest to this specific report. Yeah. Coronary physiology parameters has been widely introduced for evaluating the presence of ischemia instead of traditional QCA. I think more than 20, 30 years ago, when I learned my PCI, I may depend on QCA. But coronary flow reserve with this catheter-mounted Doppler crystal by the tip of this catheter by measuring the coronary flow velocity in the 1970s. And afterwards, since 1993, I think by Nico Paz and Bernard Debreu, they introduced this FFR instead of flow wire, instead of the Doppler crystal. They use the pressure sensor, with what we call pressure wire today. And multiple randomized trials showed that the benefit of FFR in conducting the PCI and the conservative therapy, especially in the intermediate lesions. Recently, dozens of FFR surrogate have been implanted, such as QFI, I think in China. This is an implant developed in China, and IFR, CAFFR, CAIMR, RFR, etc. However, this FFRs is a surrogate of myocardial ischemia by assessing the luminal narrowing of the epicardial coronary vessel without any information of the microvasculature or microvascular dysfunction. So therefore, another parameter for the diagnosis of microcirculatory dysfunction, we call index of microcirculatory resistance, recently reported with CAIMR, is now showed increased importance. Yeah, the penetration of the intracoronary physiology, actually, we introduced in 1999, but the penetration of the whole China is still less than 5%. You know, in 1999, the annual PCI volume was 8,000, less than 10,000 per year. But by the year 2019, the 20 years after, the annual PCI volume was over 1 million each year. Therefore, I know that in Northern Europe, it's more than 1/3 of PCI you will do physiology guided, but in our whole population, we still less than 5%. At present, as we mentioned in this demonstration, that we conducted this angio-guided FFR or microcatheter. Now, in 1999, we introduced this technique, but in the early years, it developed very slow, even though we have our consensus or guidelines by our society for using to guide the PCI, but it is very not commonly used. If we look for the reason why, I think because in China, the development from east and west part is very uneven. The recognition of physiology is not equally. Secondly, I think more importantly is reimbursement, because the flow wire is more costly than a coronary stent. Therefore, the operators rather to put a stent instead of using the wire to re-evaluate. And third is the limitation of the current instrument. For example, for the torture solutions by the beginners, they do not used to use the wire, and also the difficulties to use, as I mentioned. Therefore, we developed this pressure microcatheter, as mentioned, and because it has less drift, and it is with a very small profile, using this piezoelectric pressure technique, and compared to this the Physio, the micro pressure catheter, to the pressure wire, we did pilot studies previously, and we compared. This is the device. We compared the true Physio pressure microcatheter and to the pressure wire. We also compare the parameters of another monorail system, which is using the optical mechanism. And the profile of this pressure wire only 0.02 inch, and which is very small and to cross every lesion. And after we conduct a multi-center Supreme trial, and which was published recently, and we conducted the multi-center clinical trial to compare FFR and this FFR derived from the pressure microcatheter, and we do find that there is a very good consistency with the two methods, and the new device is a pressure microcatheter has less drift and more stable position. And therefore, we now, by analyzing this subgroup analysis, we now coined a new index we call constant resistance ratio, that without injection of a vasodilator. And this constant resistance ratio we call CRR. We are now doing a clinical trial, and this trial is ongoing in China with 11 centers. We are trying to identify if this CRR is equally feasible to the FFRs using the vasodilator. In addition, I think we are now joining the trial conducted by Dr. Barboto, the international trial. We try to enroll more patients to see the significance of the pressure microcatheter and the pressure wire, what's the difference, and we try to push this intracoronary physiology forward in China, because we have annually more than 1 million PCIs. We hope in the future more and more operators could be convinced to use this for the guidance of coronary intervention. Thank you very much. This is the current status in China.
Thank you, Professor. Thank you, Professor Jumbo-Ge. Thank you for sharing this data with us. We are near to the closure, so Emanuele.
Yes, if we can have the key learning slide on the screen, just to summarize what we discussed from the backstage. Anyhow, I will just go through them. I hope you would concur that invasive physiology is here not just to indicate, but also to guide stent implantation. That was really the topic of this session. We believe that pressure microcatheter reliably enables and facilitates multiple functional assessments before, during, after PCI, as we had the opportunity to discuss, with no impact on procedural setting. The insightful FFR trial will provide novel evidences in support of pressure microcatheter guided PCI. With this, I thank you again, my colleagues here with me in the panel, Professor Ge, connected from China, the sponsor who made this session possible. Good continuation of the Congress. Thank you.